Thank you very much, Dr. Madhumani. Good afternoon, everybody. So, first of all, I must thank the organizing committee, KSM, Dr. Madhumani, and the team for giving me this opportunity. I think we are running behind time. So, management of anaphylaxis. Why am I going to talk about management of anaphylaxis? This is a very familiar topic for you all, I think, from our time in medical school. So, anything new in the guidelines? Why am I going to talk about this again? Let's find out. So, these are some facts. Can you all hear me? Okay. These are some facts. Says many patients with anaphylaxis are not given the correct treatment because of failure to recognize anaphylaxis. Conversely, prominent skin features may be misdiagnosed as anaphylaxis and treated with adrenaline. More alarmingly, it says about half of the cases of anaphylaxis are not treated with adrenaline even when it occurs in a healthcare setting. So, what's gone wrong with our management? It seems there's something wrong. So, according to these facts, it seems the problem is mainly with recognition of anaphylaxis and initial management, which I'm going to focus on. In the overview, I'm not going to go into details of definitions and pathophysiology, which were dealt with in detail by Dr. Danushka in the first presentation. My main focus is on initial management of anaphylaxis and a word about refractory anaphylaxis, which again was dealt with. Finally, investigations, recovery, and follow-up. Coming to case scenario, a 35-year-old female coming to the A&E feeling tight-chested. She's allergic to beef, but she's not sure whether she had it in her last meal, which she had from a restaurant. On examination of the ABCDE, airway is fine, breathing is okay, blood pressure 110/60 with a pulse rate of 96. She's alert but a bit anxious. There are no skin manifestations. But over the next 10 minutes, she becomes very short of breath, got widespread wheeze, develops an urticaria rash, and feels lightheaded. So the vital signs are now much different from the previous. She's now complaining of tightness in throat. She's a bit tachypneic at 32 breaths per minute with widespread bronchi. Blood pressure has dropped markedly. Now it's 80/60, tachycardic, quite anxious, with widespread urticaria. So what do you reckon? You have got a detailed account on recognition and diagnosis of anaphylaxis. So you know now this presentation. With this presentation, we can diagnose anaphylaxis in this patient. Definition. There, you heard several definitions of anaphylaxis. I'm not going to go into details. The bottom line is, it is an acute onset illness associated with airway, breathing, circulatory problems, plus or minus skin manifestations. So you know that skin manifestations may be there, may not be there. But for you to diagnose anaphylaxis, there must be either airway or breathing or circulatory involvement. As Dr. Danushka mentioned, if it is related to GI symptoms, severe and persistent GI symptoms in the absence of food allergen, again you can diagnose anaphylaxis. But you all skin manifestations are not good enough to diagnose anaphylaxis. Points to emphasize again, skin or mucosal changes alone are not a sign of anaphylaxis, and skin manifestations can be very subtle or absent in up to about 20% of cases. To make the things more complicated, it says that in up to 30% of cases, there will be no triggering agent. Pathophysiology, I'm not going to go into details. As you heard, it's secondary to massive release of array of mediators from mast cells and basophils, leading to mainly fluid extravasation and vasodilatation, producing the life-threatening airway, breathing, and circulatory issues, namely bronchospasms, low blood pressure, and shock, and acute upper airway obstruction as well. Sorry about this slide. This is from the 2021 Resuscitation Council guideline protocol for management of anaphylaxis. I'll explain each step. Coming back to our case scenario, this young lady coming to A&E with history of possible exposure to an allergen, who has got airway, breathing, and circulatory compromise along with skin manifestations. Now she has got life-threatening symptoms involving airway, breathing, and circulation. Coming to the initial management. So as for any medical emergency, it's with an ABCD approach, as you all know. You have to treat the life-threatening problems as you find them then and there. Call for help. You are very likely to need help of an additional pair of hands at least. Remove the trigger if possible. In the case scenario, it's not possible, but if the patient is on a drug infusion, so blood transfusion, you can stop the possible trigger and get someone to establish monitoring of the vitals, that is pulse oximeter, non-invasive blood pressure, and the ECG. In the ward setup, or A&E, or the ICU, what you should have in your emergency trolley to manage a case of anaphylaxis. Equipment wise, it's mainly the airway equipment, and drugs wise, it says adrenaline, that is our popular 1 in 1000 glass vial containing 1 milligram of adrenaline in 1 ml, and 1 ml syringes and the needles, and some saline and IV access equipment. There is special emphasis on patient positioning in the latest guidelines. The ideal position, as you all know, is to lie flat, ideally with the legs up. But if most of the time the patients are happier to stay seated up, especially when they get bronchospasms, that position is also acceptable. But you should never ever allow a patient to get off the bed and stand up, which can lead to acute cardiovascular decompensation and cardiac arrest. Intramuscular adrenaline. This is the treatment, first line treatment of anaphylaxis in all settings. In previous guidelines, it was said that IV adrenaline can be given in perioperative anaphylaxis, but in the later guidelines, they say in all the settings, IM adrenaline is preferred. So adrenaline treats all the life-threatening ABC complications associated with anaphylaxis. That's why it has become the treatment for anaphylaxis. So as I mentioned earlier, after removal of the potential trigger, positioning the patient safely, the next thing is adrenaline. Not your chlorpheniramine, no hydrocortisone, no anything else, not even oxygen. So adrenaline treats the peripheral vasodilatation and tissue edema, the bronchoconstriction, low blood pressure, and also it suppresses histamine nicotine release as well. So as you can see, adrenaline can treat all the life-threatening complications of anaphylaxis associated with airway, breathing, and circulation. Intramuscular adrenaline, you have to use from that glass vial, undiluted, drawn into 1 ml syringe. For an average adult and children more than 12 years, the dose is 500 miles. That is 0.5 ml of the content of the glass vial. The weight adjusted dose is 0.01 milligrams per kg per dose. In the settings where you get pediatric patients, like in A&E or pediatric units, it's good to have a chart with weight-based adrenaline doses. So there's not going to be any delay. Otherwise, it's 0.5 ml of your glass ampule. And about that resuscitation trolley, resuscitation equipment, even in the ward setup, it's good to have a adrenaline pack to be used in anaphylaxis. Anaphylaxis pack. The anaphylaxis pack should contain only adrenaline. No other drugs are needed. So 1 or 2 hours of adrenaline with 1 ml syringe and needles. That should be the content of that adrenaline pack. It's good to have in the ward setup. So there won't be any delay in giving the adrenaline dose. And the important thing is you can repeat the dose after 5 minutes if there are still ongoing ABC complications. Then comes oxygen. You have to start oxygen as soon as possible. Initially start with a non-rebreathing mask. Then you can titrate according to the saturation. You can do a blood gas measurement when feasible. Even if the patient is not desaturating, the patient is diagnosed as having anaphylaxis, you have to start on oxygen. You can later de-escalate. IV fluids. As soon as you get peripheral venous access, you have to give IV fluids, crystalloids, mainly normal saline or maybe Hartmann's. In an average adult, you have to give at least 500 to 1000 ml as a bolus and then titrate according to the response. It's good to give 500 and see the response and give another 500 and then start on 100 ml per hour infusion. Then you can adjust accordingly. But they say in severe anaphylaxis there can be huge fluid extravasation causing loss of intravascular fluid, so might need large volumes of IV fluids, maybe even up to 6 to 7 liters even. Colloids are not indicated. You have to always reassess the patient, go back and reassess and see whether the ABC problems are solved. If the ABC problems are still there, ongoing, you have to repeat the adrenaline dose after 5 minutes. It's the same dose. Antihistamines, your popular chlorpheniramine, it's not recommended as part of the initial emergency treatment anymore. It's considered a third line intervention. Chlorpheniramine and other antihistamines have no place in treating respiratory or cardiovascular symptoms associated with anaphylaxis. It can be used to treat skin symptoms, but it should never delay your adrenaline dose. Once the patient is stabilized, you can use a non-sedating oral antihistamine like cetirizine rather than chlorpheniramine. Coming to steroids, again, routine use of steroids is no longer advised. You can consider steroids after initial resuscitation for refractory reactions. The primary action of steroids is to downregulate the late phase inflammatory response, so it's not going to help your initial management of the life-threatening symptoms. I still see people giving corticosteroids before adrenaline. That still happens even in ICU setup. So please don't. It's not going to help the life-threatening problems of the patient. Refractory anaphylaxis was dealt with during the previous lecture, so I'm not going to go into details. The one thing that I want to mention in this slide is that refractory anaphylaxis can happen as a result of delayed or insufficient delivery of adrenaline. So that again emphasizes the importance of timely adrenaline dose. Refractory anaphylaxis is defined as ongoing ABC manifestations despite 2 doses of adrenaline. So whenever you get continued ongoing life-threatening symptoms, even after the 2nd dose of adrenaline, you have to contact ICU. So the patient is very likely to need ICU care. The management of refractory anaphylaxis is to optimize delivery of adrenaline again. So need to set up IV adrenaline infusion. IV adrenaline should only be used by people who are experts in using intravenous adrenaline, because you know the side effects can be life-threatening, which can cause severe hypertension, severe tachyarrhythmias. stroke, or even MI. So it has to be used by experts only. IV fluids needs to be continued, and monitoring needs to be continued. So the low dose adrenaline infusion can be set up in the ward setting, but under direct supervision by a specialist. You can mix 1 vial of your adrenaline into 100 ml of normal saline and start at 0.5 to 1 ml per kg per hour, and then adjust according to the response. But at this stage, patient is very likely to need a central venous access, and you may have to consider second vasopressin. The second line is generally vasopressin, but the patient needs to be in critical care setup by that time. Even metraminol can be used peripherally, but not freely available in our setup, quite expensive. So, as you all know, any medical emergency can be managed with the ALS approach, with some modifications for management of anaphylaxis. Removal of the allergen, early adrenaline, and predict possible difficult airway, and have a very low threshold to go for early intubation by an experienced clinician, and IV fluids to manage shock, and additional drugs. Master tryptase, I'm not going to go into details. Other basic investigations you must send as for any medical emergency, that is full count, urea electrolytes, blood gas, and chest x-ray. Apart from that, master tryptase is not freely available, I assume, so I'm not going to go into details. Biphasic reactions. This is a recurrence of anaphylaxis symptoms after complete resolution of the initial complications. There are several risk factors to develop biphasic reactions that you have to keep in mind. Very severe initial presentation, initial reaction requiring more than 1 dose of adrenaline, delay in adrenaline administration, and previous history of biphasic reaction. So in these cases, you have to be careful on deciding timing of discharge. Timing of discharge. Actually, there is a risk stratified approach to decide the timing of discharge after anaphylaxis. It says this fast track discharge, that is after 2 hours of complete resolution of the symptoms. You can consider when there was a good response to a single dose of adrenaline, plus there's complete resolution of symptoms, and the patient already has this adrenaline auto injectors, which we don't have in our setting, the EpiPen, and there is adequate supervision following discharge. The next group is 6 hours observation after the initial anaphylaxis. If the patient had 2 doses of IM adrenaline, or there is a history of previous biphasic reaction, then you need to keep the patient under observation for at least 6 hours. Next group is 12 hours observation, that is severe reaction requiring more than 2 doses, patients having severe asthma, and possibility of continuing absorption of allergens, and where you cannot guarantee that the patient can come urgently to a setup where resuscitation facilities are available. Actually, in our setup, in Sri Lankan setup, we cannot rely on the first 2 groups. We cannot follow that guideline, I think. So in our setup, we have to keep the patient under observation for at least 12 hours after any degree of severity in the anaphylaxis. Patient education is important, and record keeping. Dr. Nadisha described about the importance of record keeping. So as she mentioned, it's very important to give a good account of what happened, what were the symptoms, the timing of symptoms, with a proper time frame, what were the treatments according to the symptoms the patient got. So few things of note before I conclude. skin changes alone are not a sign of anaphylaxis. I know that patients can present with very striking skin manifestations like widespread urticaria that you feel like giving adrenaline on the first instance, but please don't. Anaphylaxis, to define anaphylaxis, there must be airway, breathing, or circulation problems. Skin changes are absent in up to 20% of cases. So it's all about A, B, C problems and nothing about skin manifestations. That's the bottom line. And in up to 30% of cases, there will be no triggering agent. Steroids are not to be used routinely in initial management of anaphylaxis. And anaphylaxis is commonly suboptimally treated. There's no precise definition in it actually. It's a clinical diagnosis. So if in doubt, give it. Give IM adrenaline. Nobody can blame you for giving IM adrenaline if you can rationalize. So please drop your hydrocortisone, please drop your chlorpheniramine, please give IM adrenaline. So that is that concludes the presentation.